Vikas, now we're going to move on and have you discuss the issue of persistent pulmonary hypertension, if you will, persistent elevated pulmonary pressures in the face of having done a pulmonary embolectomy, and how do you manage that, and what are the acute implications and the follow-up implications of that? So perhaps you can tell us about that.
So revisiting our previous case and talking about the hemodynamics one more time, if you guys notice here, the cardiac index improvement was striking. It went from 1.4 to 4.2. The pulmonary artery mean pressure stayed at 36, starting out at 38. Despite a systemic blood pressure improvement, and inotropes and fluids were administered so as well. A result like this makes you wonder, why do some people have an elevated pulmonary artery pressure in the setting of an acute pulmonary embolism, and why some respond dramatically and the PA pressure normalizes, so while in others it stays elevated? What are the three potential mechanisms for a PA pressure elevation in a patient who's having an acute pulmonary embolism? Septal shifting towards the LV because the RV is dilated and hypokinetic can potentially increase the filling pressure on the left side, which would then translate into an elevated pulmonary artery diastolic pressure and eventually leading to an elevated pulmonary artery systolic and pulmonary artery mean pressure. A patient could also have somewhat subacute or chronic pulmonary artery obstruction, which has now led to pulmonary arterial hypertension, or they could have pre-existing pulmonary arterial hypertension from one of many causes. Understanding pulmonary artery pressure elevation during an acute PE intervention as well as the implications in follow-up will help you to guide patient care further. So septal shifting towards an LV is common. It's especially common in those who are in shock, normotensive or hypotensive, and can be easily recognized on echocardiography, as we saw in Dr. Bangalore's case here. Underlying pulmonary arterial obstruction is essentially a leftover stigmata of a pulmonary embolism event that happened in the past. And we know acute pulmonary embolism can sometimes lead to a chronic thromboembolic pulmonary disease as well as chronic thromboembolic pulmonary hypertension. The incidence of these complications is in the realm of 20 to 25% for chronic thromboembolic pulmonary disease and 2 to 3% in the realm of chronic thromboembolic pulmonary hypertension. And we want all our patients, with an acute pulmonary embolism, to have a complete recovery. The screening test of choice for follow-up in these patients happens to be a ventilation perfusion scan and not a spiral CT angiogram that you would otherwise get. So in a patient with acute pulmonary embolism, and confirmation is done on an invasive pulmonary angiogram. So what do you see if you do an angiogram in such patients, right? So what you see on the screen right now is a patient with an acute pulmonary embolism in which the clot shows up as a filling defect in the pulmonary arterial branches. However, you can see how the contrast is able to escape around the clot and still reach the distal pulmonary arterial vasculature. This is acute pulmonary embolism. On the other hand, those who have chronic pulmonary embolism will not have this striking pulmonary arterial haziness that you see in the acute pulmonary embolism space, but you will see these moth-bitten perfusion deficits in the lung parenchyma and these obstructed pulmonary arterial branches, despite not having that haziness in the lumen. And in these patients, the residual clot often is adherent to the wall and not floating in the lumen. This is chronic disease. This is chronic pulmonary embolism. Now, can you have both? You can absolutely have both. If you see the lung on the right here has evidence of chronic pulmonary embolism, but the lung on the left in the left main pulmonary artery has a new acute pulmonary embolism. Having this understanding, taking care of these sick patients both acutely as well as in follow-up is critical for a good patient outcome. Now, you can also have a normal pulmonary angiogram. So the most recent AHA, ACC Multi-Society Pulmonary Embolism guideline document does a great job in outlining how we should systematically care for these patients who have ongoing symptoms, residual pulmonary hypertension, after surviving an acute pulmonary embolism event. We want to give everybody at least 3 months on anticoagulation before we start any more workup. So if a patient has persistent symptoms of exercise intolerance, not being back to their fully functional pre-pulmonary embolism baseline, you could either start by working them up with imaging or with a cardiopulmonary exercise testing to evaluate for functional limitations. They are both a class 2A recommendation. And if you do find a phenotype in which they have evidence of abnormal lung perfusion more than 3 months after an acute pulmonary embolism, along with evidence of leftover RV dysfunction, pulmonary hypertension, that makes a diagnosis of chronic thromboembolic pulmonary disease with or without pulmonary hypertension possible or likely. These patients then deserve to be seen at an expert center that has the ability to further work them up with invasive pulmonary angiograms and offer them advanced therapies such as pulmonary thromboendarterectomy, balloon pulmonary angioplasty, as well as a pulmonary vasodilator therapy, so that we can get every patient with an acute pulmonary embolism to a complete recovery. You start with a pulmonary embolism clinic. A pulmonary embolism clinic is a great way to bring everybody together. You not only talk to your patients, but you evaluate their symptoms in a structured questionnaire with quality of life parameters. Cardiopulmonary exercise testing plays a big role in trying to decide between a peripheral limitation or a cardiopulmonary limitation. And I call these patients who have an isolated peripheral limitation after surviving a pulmonary embolism as people who need prehabilitation. They need to go to exercise therapy and a rehab before you do anything. That intervention alone can take care of the vast majority of their problems. On the other hand, if they truly have a cardiopulmonary limitation, that's when an expert pulmonary hypertension CTEPH center comes in and we can offer them advanced therapies such as PTE or BPA. We looked at this in the literature and noticed that there are very few studies coming from small single center experiences that look at cardiopulmonary exercise testing after an acute pulmonary embolism. This article highlights the need for us to come together and collect our data in such patients in the follow-up of pulmonary embolism together so that we can learn more on this topic and offer these patients the right personalized care they need. The pulmonary hypertension definition now happens to be a mean pulmonary artery pressure of greater than 20, so with a pulmonary vascular resistance of greater than 2 Wood units, that would make them pre-capillary pulmonary hypertension. And our goal and aim should always be to get our patients to below these numbers. The Europeans agree with us, and they also say in their guidelines to have a class 1 recommendation to follow these patients systematically in an organized fashion and work them up for chronic PE after surviving an acute pulmonary embolism. Now, we know 20 to 30% of all acute PE survivors are going to have chronic thromboembolic pulmonary disease with or without pulmonary hypertension. But those data were collected in the era of when the definition of pulmonary hypertension used to be a PA pressure of more than 25 and a PVR of greater than 3. Now, by moving the goalpost to 20 millimeters of mercury, PVR of more than 2, are we now looking at even a larger pool of patients that can potentially benefit from a comprehensive pulmonary embolism treatment approach? Because our goal should always be to bring the patient back to normal hemodynamics and complete recovery after surviving an acute pulmonary embolism. Thank you for your time.
That was fantastic, Vikas. A great summary about acute versus chronic. And I think we're still got to get a better handle on which patients are at risk for chronic versus those that are just presenting with acute issues, and then how to prevent it. I don't think we really know the best way to deal with that right now, but let's just unpack this a little bit. The patient that Sripal described had persistent elevated pulmonary pressures at the end, although the cardiac output was improved. And Catalin, doesn't that make the case for measuring hemodynamics during the procedure, not just measuring PA systolic pressure, which is what a lot of people are still doing? Just, what's the end point of a procedure? We're going to get to that a little bit more, but what is the end point of a procedure? Is it just measuring PA systolic pressure? And in that case, Sripal, you wouldn't have ended because your PA pressure was still the same. It required you to measure the hemodynamics as well, to measure cardiac output, to say we've accomplished a lot here. What are your thoughts about that, Catalin?
Well, I mean, we'll talk about that in my presentation actually a little bit. It's there's a very simple parameter that you can look at that's called the TPVR, right? Which is extrapolation of the PVR. You don't want to measure wedge pressure in this patient, so it's simply a ratio between the mean PA pressure and cardiac output. And if you calculate that for that case, you'll see that there's marked difference between where you started and where we ended, and that's probably the most accurate measurement of vascular obstruction in PE in my mind. Assuming, of course, that the wedge stays the same, which probably went up a little bit in your case because of the fluids, assuming that you're not on inotropes, which is probably a little bit the case too. But that really reflects and tells you about this case, because there are cases where you see the PA pressure doesn't change that much, but that's just because you have a more vigorous RV now that can pump and generate said pressure. And the TPVR is the marker that will illustrate all that.
But it requires you to actually have a gauge on what's the cardiac output.
Of course, yeah.
And,
yeah.
And that may not be present in many labs, I think, but it again emphasizes the importance of hemodynamics both before, during, and then again, of course, as you point out, after the acute event, and even during the actual procedure, which I'm not sure is across the board what's being done right now, but we need to encourage people to do. So how do you, Vikas, maybe you could speak to the issue of patients presenting. Are there any clues that a patient may have already got a chronic component to their PE when they present with an acute PE?
Yeah, that's a great point. So there are several clues. The first one is, so when you talk to the patient, you have to go into the depths of, so when did they actually start becoming symptomatic? So most people would try to minimize their symptoms and would often say, I've been short of breath for 2 days. But then when you talk to them further along, you will find out they've actually feelings not so well for the past 6 months, but now over the past few days, they've been feeling a lot worse. So taking a good history, talking to the patient would give you some clues to seeing if there is some chronicity. Then beyond that, the imaging data that you have in these cases before you go to the lab, meaning a transthoracic echocardiogram, can give you some clues if the pulmonary artery systolic pressure in a patient with an acute pulmonary embolism is greater than 60 or 70 millimeters of mercury, that's a red flag. It's possible that there may be a chronic component. It could also be acute, but the acute PE would have to be so significant hemodynamically, and the septum so would have to shift significantly towards the left side for just an acute PE to give you a PA pressure so that high. And the third and the most important one is how you look at that CAT scan. So I call it the donut sign, which basically is you see the contrast on your spiral CT, and if you see the contrast go around the clot, so with the clot being in the center of the blood vessel, that's most likely to be acute. However, if you see the contrast go through the clot in the middle, with the clot being adherent to the vessel wall, that it's adherent enough to not allow any contrast to be able to squeak by between the contrast and the wall, that's chronic. So having some signs would always give you the clue. You will never know 100%, and that's why, so we'll go back to Sripal's case, doing a right heart cath, so getting a cardiac output, and making a correlation between the obstruction, the hemodynamics, so will help you decide if this is acute on chronic, or only chronic.
Okay, that's a great point. So Sripal, you have a patient that has an acute PE, and their pulmonary artery systolic pressure is 95. Are you going to handle that in a different way? Does that affect your procedural decision-making and management?
Yeah, no, I think that does play a role. If the pressure is that high, and of course, it all depends also on where are we standing with the systemic ones. Are we near systemic pressures? And many a times, I remember at least 1 or 2 where we said, oh, let's pause here. Are we dealing with CTEF? Is this more of a chronic component and what is the actual acute component of it, because what we have also seen is these are the patients who are going to crash in the cath lab. So if you rush through the process of saying but then there are I wouldn't say 95, then there are borderline 65, 75 where you're not sure whether is it all acute, and we have had dramatic improvements in symptoms with mechanical thrombectomy, with the pressures.
Catalin, any comments about that? I think you have a huge experience with treating these acute patients, and including acute on chronic. Some of them must have had acute on chronic.
Absolutely. And I think you have to combine the data, right? It's not just the PA pressure being high. If they have central clot, if you think you can access the clot and take it out, I think you can get a good result even if the mean PA pressure is 80. It's not going to go to normal. These patients probably have a reason to have high PA pressures, may that be CTEPH or something else. But I think, in combination with now on the other hand, if the CT looks like it's mostly chronic, it's wall adherent clot, this is an excellent point that it's actually fairly easy to observe on a CT. In that case, I may pause and, talk to the surgeons or look at different options.
But it might be a little bit more dangerous going in for an acute clot if
absolutely.
Acute on chronic.
So I think
pressures.
So I think you have to understand how much good can you do and how much damage can you do. And if that's in the positive range, then go ahead and do it. It may be in the negative range for a patient with a mean PA pressure of 90 with chronic clot, because you may not be able to get anything out.
Sage advice. Thank you.